Welcome back to the Deep Dive. This session is built specifically for you, diving deep into a crucial topic for your MSRA revision. We've got the source material right here, and our mission is, well, to pull out every single high-yield fact.
Exactly. And clarify anything that might trip you up, make sure it really sticks.
Think of us as your guides through this. Today we're tackling a really common condition, one you'll definitely see, impetigo.
Absolutely. Exams, clinic, it pops up everywhere. We're going to unpack everything the sources give us, basics to the nitty-gritty details you need.
Okay, let's jump right in. What exactly is impetigo at its core?
So the definition is pretty clear. It's a contagious bacterial skin infection.
Bacterial contagious. Got it.
And the big demographic to remember, it primarily affects children.
Right, kids.
Yeah.
And the visual, because that seems pretty key here, doesn't it?
It is, definitely. You'll see small red sores, maybe blisters initially. But the real giveaway, the thing that should scream impetigo, is when these sores rupture. They form this characteristic, kind of sticky, honey-colored crust, like a golden brown glaze.
Ah, the honey-colored crust. That's the picture to remember. And where does this usually show up?
It tends to like areas where skin is already a bit moist or maybe injured. So common spots are the face, especially around the nose and mouth, flexures to like elbows behind the knees, and just generally exposed limbs. Anywhere a kid might get a scrape or an insect bite.
Got it. Bacterial, kids, honey crust, specific locations, and the bacteria causing it.
The usual suspects are Staphylococcus, aureus, or Streptococcus pyogenes. Those are the two main culprits.
Okay. The sources also mention primary versus secondary impetigo. What's that distinction about?
Yeah, it's quite simple, really. Primary means it develops on skin that was totally fine before, completely intact.
Right.
Secondary impetigo, which is actually more common, starts where the skin's already damaged, maybe eczema, a cut, a bite, even scratching too much.
Ah, okay.
Basically takes advantage of that break in the skin barrier.
So secondary is like an infection jumping onto existing skin trouble. And you said it's super common in kids, especially when?
Especially in warmer weather. The bacteria seem to thrive then. And importantly, while Staph and Strep are the main players, the sources note an increasing mention of MRSA.
Methicillin-resistant Staph aureus.
Exactly, which obviously has implications for treatment choices later on.
Okay, so bacteria get in through skin breaks. That brings us neatly to the etiology of the cause. Besides Staph and Strep, what helps it get started?
Well, like we said, the bacteria need that entry point. So even minor things, small cuts, little scrapes, insect bites, they're really important. They create that initial breach.
And once the bacteria are in, how does it spread so easily? Person to person or even on the same person?
Oh, it's highly contagious. The main way is direct contact with the fluid or pus from the sores themselves.
Right.
But it also spreads indirectly. Think contaminated objects, towels, clothes, toys, anything that's touched the infected skin.
So shared toys in a nursery or towels in a family bathroom. Makes perfect sense. The sources also list factors that increase the risk of it spreading. What are they?
Yeah, they highlight things like poor hygiene and crowded living conditions as significant factors. More people close together just makes contact, direct or indirect, much more likely.
That feels like a classic MSRA scenario setup thinking about the context. So putting it all together, what are the key risk factors we absolutely need to file away?
Okay, the big ones. Definitely close contact with someone who's infected. That's kind of obvious but crucial.
Sure.
Participating in contact sports, skin-to-skin friction, potential minor injuries, warm, humid environments where bacteria just love to grow, compromised skin integrity, so cuts, bites, but also underlying conditions like eczema, and finally, having a weakened immune system.
Right. So you can picture that vignette. A child starts daycare or joins the rugby team, develops lesions. Knowing those risks helps pinpoint impetigo. It's pattern recognition.
Exactly. Those contexts are hotspots for spread.
Now, let's get into the pathophysiology. Bacteria get in, we know that. But what are they actually doing in the skin to cause those sores and crusts? Keep it simple for us.
Okay. Think of it like this. Bacteria enter, they start multiplying fast. A key thing, especially with Staph, is they release toxins.
Ah, toxins.
Yeah, and these toxins actually damage the skin cells directly. It's that damage that leads to the blisters or sores forming, which then rupture.
So the toxins cause the physical damage we see.
Precisely. And then we loop back to spread scratching. When a child scratches an itchy sore, they can spread the bacteria to new bits of their own skin.
Creating new lesions.
Exactly. And they contaminate their hands, which then touch surfaces, other people. You get that cycle of spread.
The scratch and spread cycle. Very clear. Okay, before we talk confirming diagnosis, we have to consider lookalikes. Differentials are critical for MSRA. What's on that list?
It's quite a list, actually, which really underscores why knowing the classic Impetigo features is so vital. The sources mention things like cellulitis, contact dermatitis, scabies, various viral skin infections, herpes simplex, herpes zoster, varicella zoster, so chickenpox or shingles,
Right.
bull's pemphigoid, erysipelas, intertrigo, atopic eczema, especially thinking about secondary impetigo on eczema, burns, even Stevens-Johnson syndrome, and toxic epidermal necrolysis, though those are much more serious.
Wow, that's a wide range. From simple irritations to really severe stuff, the length of that list alone tells you. Lock onto the specific signs of impetigo to navigate the differential.
Absolutely.
Yeah.
You need to rely on those hallmarks, the honey crust, the type of blister to say, okay, this looks like impetigo, not one of these others.
Let's zoom out briefly for epidemiology. Who gets this most and where?
The data is pretty clear.
Yeah.
Most common in young children, specifically aged 2 to 5 years.
Toddlers and preschoolers.
Exactly. In the UK, the estimated annual incidence is quite high in that group, about 2.8% for under 4s, and still significant at 1.6% for kids aged 5 to 15.
So quite common then.
Very. And globally, it's huge. Affects maybe 162 million children worldwide. Rates are much higher in tropical places and underprivileged areas, likely linked to crowding and hygiene factors.
Okay, quick memory jog. Impetigo loves small kids, 2 to 5, and warm weather.
That sums it up nicely. And the sources support that seasonality strep-caused impetigo often peaks in warm, humid times, and staph impetigo also rises in warmer months.
Right. Let's really dig into the clinical features now. A child presents. What are we looking for? What might they say?
Okay, generally you'll see those small red sores or maybe blisters, often on the face, hands, exposed areas. The key moment is when they break open and that yellowish or honey-colored crust forms. The child might complain it's itchy, hence the scratching, maybe some pain or just discomfort. In more severe cases, you might feel swollen, tender lymph nodes nearby.
Okay. Let's break down the two main forms mentioned. First, non-bullous impetigo.
All right, this is the classic one. You see those golden crusted lesions, often around the mouth or nose. They start as tiny pustules or vesicles, little fluid bumps, then rupture and dry into those honey-colored plaques, usually small, less than 2 centimeters.
And highly contagious.
Very. Spreads rapidly, often with smaller satellite lesions popping up nearby. Usually itchy, maybe a little redness around the edge, but not massive swelling. You can get enlarged regional lymph nodes with this form.
Okay. Golden crusts, face, quick spread, satellite lesions, maybe nodes. Got it.
Yeah.
How does the bullous form differ?
Bullous impetigo looks quite different. Instead of small crusts, you get larger, thin-roofed blisters, the bullae. They rupture really easily, leaving a moist patch before maybe a thin crust forms.
And location.
Can be more widespread, face, trunk, limbs, even buttocks or perineum. These bigger blisters can sometimes be confused with other blistering conditions or might overlap with eczema. Key differences. Usually less redness around the bullet compared to non-bullous lesions, and typically no swollen lymph nodes. It's more common in neonates, but can happen at any age. Often more painful than non-bullous, and sometimes kids feel generally unwell, maybe a bit feverish.
So, large, fragile blisters versus small crusted sores. Less surrounding redness, fewer nodes, but potentially more pain, systemic upset, especially in babies. That contrast is vital. What about eczema?
Ah, yes, eczema. Think of it as a deeper version of non-bullous. It starts similarly, but goes down into the dermis. It becomes necrotic, forming a sort of punched-out ulcer with a raised border and a thick crust.
Deeper, nastier looking.
Exactly. And because it's deeper, it's more likely to cause significant lymph node swelling lymphadenitis compared to standard impetigo.
That's really helpful. You can totally see an MSRA question describing golden crusts versus large blisters, asking for the type, or deep ulcer eczema.
Definitely. Those descriptions are the clues.
Okay, investigations. How do we confirm it? Do we swab every child?
The sources are clear here. Diagnosis is primarily clinical. You look at the lesions, take the history. Usually, that's enough.
So mostly based on what you see, when do we need lab tests, like a swab?
You'd swab in specific situations. If the impetigo is really extensive or severe, if you suspect MRSA, maybe based on local rates or risk factors,
Okay.
if it keeps coming back, recurrent cases, or if it just isn't getting better with the first treatment you try.
Resistant cases.
Right. And they also mention considering nasal swabs if you have a recurrent staph impetigo to check if the person is carrying the bacteria in their nose, acting as a reservoir.
Right, checking for carriage. So, clinical diagnosis first, swabs for specific red flag scenarios. Makes sense. What about management? treatment and, crucially, stopping the spread.
The goals are clear. Treat the infection effectively and prevent transmission. That prevention part is huge.
So the general advice for families, what's key?
Absolutely vital. Keep the area clean. Wash hands thoroughly, soap and water after touching sores. Don't share towels, flannels, bath water, and really try to stop the child scratching or picking. Simple hygiene is paramount.
Simple but critical. Okay, treatment specifics based on guidelines. Localized non-bullous impetigo. What's first line?
For localized non-bullous, if the patient isn't severely unwell or high risk, the first line topical mentioned is hydrogen peroxide 1% cream.
Hydrogen peroxide first. Interesting.
Yeah, it's there as a potential first choice is suitable. If it's not appropriate, or maybe the infection's a bit more involved but still localized, then a short course of topical antibiotics. The main ones highlighted are fusidic acid 2% or mupirocin 2%.
Got it. H2O2 cream, possibly first for simple cases, otherwise topical fusidic acid or mupirocin. What if it's more widespread non-bullous?
For widespread non-bullous, the guidance suggests you can consider either topical antibiotics again or step up to oral antibiotics, assuming the patient isn't severely unwell or high risk.
And if it's the bullous form or if the patient is unwell, regardless of type?
Then it's oral antibiotics straight away. Bullous impetigo, or any impetigo in someone systemically unwell or high risk. First choice oral is flucloxacillin.
Flucloxacillin, key name.
Definitely. Alternatives mentioned include clarithromycin or erythromycin, useful for penicillin allergy or, say, during pregnancy.
Okay, memory tip time. Honey crust, impetigo, simple, local, non-bullous, maybe hydrogen peroxide cream. Widespread or severe, flucloxacillin is the main oral drug.
That's a good summary. The sources also cover what to do if treatment fails or it keeps coming back.
What's the approach, then?
If no improvement, definitely get a swab for culture and sensitivity. That tells you exactly what bacteria you're dealing with and what kills it, guiding your next antibiotic choice.
Makes sense.
For recurrent cases, testing is vital, and if you find staph carriage, like in the nose, decolonization treatment might be needed to stop it seeding new infections.
And when do we need to refer or get specialist advice?
Refer if there are signs of serious illness, if it's widespread in someone immunocompromised. If a baby has bullous impetigos, they can get sick quickly, or if there's a high risk of complications.
And the big practical question for parents. School exclusion.
Clear guidance here.
Yeah.
Stay off school, nursery, etc. until lesions are completely dry and scabbed over, or after 48 hours of appropriate antibiotic treatment, whichever happens first.
That 48-hour rule, or dry scabbed. Classic exam point and practical advice. You could easily see an MSRA question on that, or asking for initial management based on localized non-bullous versus bullous systemic.
Those are definitely likely scenarios. Knowing the criteria and treatment pathways is key.
Nearly there. What's the general prognosis? Does it clear up well?
Generally, yes. Very good prognosis if treated promptly.
Mm-hmm.
The sources say with the right treatment, it usually resolves completely in a few weeks. How fast depends on severity, treatment effectiveness, and, crucially, adherence to those hygiene measures to stop reinfection or spread. Untreated, because it's so contagious, it can drag on for weeks, even months. So prevention helps prognosis too.
Which brings us finally to complications. What can go wrong? Especially the high-yield ones for exams.
Right, crucial section. Usually it's straightforward, but complications can happen. Locally, it can spread outwards or deeper. Think cellulitis, spreading redness, swelling, or abscesses, collections of pus.
Okay, local spread. But there are more systemic ones mentioned too.
Exactly. And this is particularly important if the impetigo is caused by Streptococcus pyogenes. Post-streptococcal complications are the big ones to know.
Tell me more. Why do they happen? What are they?
Okay, so after a strep pyogenes infection could be impetigo, could be strep throat, the body makes antibodies. Sometimes these antibodies mistakenly attack similar-looking molecules on the body's own tissues. It's like friendly fire.
An autoimmune-like reaction triggered by the strep.
Precisely. The two key ones mentioned are acute glomerulonephritis affecting the kidneys
Kid problems.
and acute rheumatic fever, which can damage the heart, joints, brain, skin.
Wow. So that link. Strep pyogenes impetigo potentially leading to kidney or heart issues down the line. Vital.
Absolutely high yield for exams, much rarer, but potentially very serious. The infection could spread into the bloodstream, causing sepsis.
A medical emergency.
Yes, and the sources also mention staphylococcal scalded skin syndrome, rare, especially noted in adults, causes widespread skin peeling, needs hospital.
So beyond local spread, remember post-strep glomerulonephritis and rheumatic fever from strep pyogenes, plus rare sepsis and staph scalded skin. You could easily see a question. history of skin infection, then weeks later joint pain or dark urine, connecting back to strep impetigo complications.
That connection between the initial infection and later systemic symptoms is a classic test.
And that, I think, wraps up our deep dive into impetigo for MSRA revision. We've covered its contagious nature, those honey-colored crusts.
The different forms, non-bullous versus bullous.
Who gets it, how we diagnose it, the specific management steps, including hydrogen peroxide and flucloxacillin.
And critically, those complications, especially the post-streptococcal ones. Remember glomerulonephritis and rheumatic fever.
Hopefully this focus session has really helped cement those high-yield facts for you. Keep going over these points.
For more free MSRA revision resources, visit freemsra.com, and for the full premium revision toolkit, head to passthemsra.com.